Okay, this is going to be a presentation on lysosomal storage diseases. I know we discussed Fabry disease and what a lysosomal storage disease was back in the spring, but we're going to do a little refresh on this and go over the rest of them. The reason I've done it in this order is so that we can follow along with biochemistry to try to make things a little bit easier for you guys as far as when you're seeing material. So the objectives include list symptoms of mucopolysaccharide disorders, MPS 1 and MPS 2, inheritance patterns and difference, recognize common clinical symptoms of MPS 1 and cause of death, determine screening and diagnostic testing for MPS 1 and MPS 2, identify the clinical characteristics and common age of onset of Gaucher disease, recognize the inheritance pattern of Gaucher disease in at-risk ethnic population, list treatment options for Gaucher, recognize the association effects of being a GBA carrier in Parkinson's disease, recognize common clinical characteristics of Sanfilippo syndrome, and finally, Pompe disease, identify characteristics and common age of onset of Pompe, recognize inheritance patterns for Pompe, and list the symptoms of infantile and adult Pompe disease. Finally, list treatment options for Pompe. So, lysosomes are intercellular organelles, and I know we discussed this before when we were talking about Fabry disease, which is another lysosomal storage disease. But basically, lysosomes are kind of like the garbage disposal. Whatever we're done with, we send to the lysosomes to be broken down, whether it be proteins, nucleic acids, lipids, complex carbohydrates. They go into the lysosome, and there are a number of enzymes that are responsible to break them down into smaller pieces, and these smaller pieces can then be eliminated from the body. Defects in various enzymes in these pathways result in the inability to either break down complex carbohydrates, proteins, lipids, nucleic acids, and so forth. When to think about a lysosomal storage disease? Well, one is organomegaly. So when we can't break things down, they accumulate. And the accumulation, a lot of this occurs in the liver, but it also results in inflammation. And as a result, we get hepatosplenomegaly. I always like to think of a storage disease. It's kind of like the basement in the garage of your house. You know, you keep shoving stuff in there, and if you don't take things out, you know, you have a hard time getting your car in the garage. Unexplained joint stiffness, again, accumulation of these byproducts as well as probably inflammation. Coarse facial features, which I'm going to go over, especially if it's progressing. Unexplained pain in children, neuropathic pain, bone pain. Loss of developmental milestones. You know, developmental delay is a better word than mental retardation, which we're trying to not use anymore. But it's also a difficult one because parents will say to me, well, is the child going to catch up? And usually, no. They'll continue to move forward, but not at the same pace as maybe some other children. Loss of milestones is far more concerning, though. It's one thing not to be going forward fast enough. It's another thing when you're going backwards. So loss of milestones, you know, Susie had 20 words 6 months ago, and now she only has 10. That is a huge red flag, and that should always be a red flag that somebody's losing developmental milestones. Mucopolysaccharidosis type 1 or MPS 1 has 3 names: Hurler, Hurler-Shea, and Shea. Why? Because prior to us knowing anything about these disorders, they were described by a physician. In the case of Hurler syndrome, by Dr. Hurler. In the case of Shea syndrome, by Dr. Shea. Hurler syndrome presents early, Shea more in adulthood. And then some people noticed, well, Hurler's technically presents before 5, but this kid is 9, so they called it Hurler-Shea syndrome. So the problem in MPS 1, but they're all MPS 1, you know, so I like to just refer to it as MPS 1, but you might see Hurler syndrome. Glycosaminoglycans are used as tissue support. And whenever we're done with something, we make new stuff. We want to get rid of the old stuff. So we send it to the lysosome. So there are a number of enzymes that are responsible of taking this glycosaminoglycan down to something small enough to be excreted from the body. And so there are a lot of steps here. In the case of Hurler syndrome, the enzyme alpha-1 iduronidase is not working right. So here's the enzyme alpha-1 iduronidase, and it breaks this little piece off. So you can see this is getting shorter and shorter. The amount of residual enzyme is what determines if it's Hurler, Shea, or Shea. So 0 enzyme is Hurler's, maybe 5% is Hurler Shea, and maybe 10% is Shea. So the amount of residual enzyme determines like the semantics of what you call it. Genetics of MPS I, it's inherited in autosomal recessive fashion, so there's 2 copies of this gene. Both make 100% enzyme, so as long as you got one, you're good. But if you have one that makes none and one that makes a little bit, that's like a mild form. If you have 2 that make nothing, then that's Hurler's. Carriers are asymptomatic. It affects all ethnic groups, and it occurs in about 1 in 100,000 individuals. So it's pretty rare. But anyway, MPS I clinical characteristics include a short nose that's kind of upturned. You can also see a flat face, prominent forehead, large, and it's usually macrocephalic, like a large head. These lips are thick. Again, here's this upturned nose, and we have contractures of the fingers. I once had a girl that was diagnosed with Hurler Shea. She presented around 6 or 7, and she couldn't do the monkey bars. They're usually normal at birth, but become more progressive over time. So here is a little girl at 10 months with MPS I, and she looks pretty normal. A little bit of that upturned nose, but I doubt I would have noticed it. And here she is at 12 months, and I think she looks like a completely normal kid. And that's what happens to the pediatrician. They're seeing this kid over and over and over, and what happens because of all this stuff, they come home with ear infections, sinus infections, blah, 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 blah. And you don't notice this progression, and then all of a sudden, here she is at 22 months. And what is this striking difference? Well, you can see kind of stuff coming out of her nose, but her lips are getting thicker. Her cheeks are getting bigger. And here she is at 39 months. By this time, she's having so much respiratory stuff, she has to be on oxygen. But again, her lips are thicker, her cheeks are getting bigger and bigger, her eyebrows are getting bushier, and you can see how big her head is. So, it's a progressive thing that sometimes, sometimes, especially if you see the kid every day, you might not even recognize. I always say that the ophthalmologist is my best friend, and part of the reason for that is because when things are accumulating, the cornea is a very thin membrane, so we're going to see that first. So we can see corneal clouding, and it's kind of a ground glass appearance, glaucoma and retinal disease, chronic rhinitis, chronic otitis media, as I was saying before, like they come in all the time. They need PE tubes, they always have an ear infection. When you get into peds, you'll notice that's pretty common of a lot of kids, but so you don't think of it that much until other things start happening. Cardiovascular, vascular disease, cardiomyopathy, and this is actually the most common cause of death. CNS, hydrocephalus, progressive developmental delay. And as I was saying, progressive, it's one thing for a child not to be moving forward. It's another thing for them to be going backwards. Skeletal manifestation is the gibbous. This is the gibbous, and it's kind of the vertebrae collapse upon itself, and that's a specific finding that we can see in young children. Sometimes the first sign of MPS I. Abnormal clavicles, hip dysplasia, and then here's this claw hand deformity. Like I said, the little girl that couldn't do the monkey bars, they just can't, grab onto them. Joint stiffness, growth retardation. So diagnosis. Urine glycosaminoglycans is an inexpensive screening test to look for mucopolysaccharides disorders. if it's on your differential. Dermatan and heparin sulfate are both elevated in patients with MPS 1 and MPS 2. Enzyme analysis and molecular analysis is needed to confirm specific diagnosis. One of the reasons I usually have to take these lectures every year is because things change so much in genetics. And 10 years ago, I would only do urine, and then I'd follow up with enzyme. Now, probably the most cost-effective, probably even cheaper than doing urine mucopolysaccharides or glycosaminic glycans, is just doing DNA. Most affected patients have less than 1% of enzyme activity for the alpha-1 iduronidase, so I'd almost like back up if I found 2 mutations, especially if I had a question, I'd then look at that particular enzyme. DNA analysis for the IDUA gene identifies 2 gene mutations in 100% of patients affected with Hurler syndrome. So here we have Hurler syndrome has pretty much no enzyme, and most of these patients die of cardiac and respiratory complications before age 10. Shea has maybe 10%, Hurler-Shea maybe 5%. So as I was saying, one gene probably doesn't work at all, and one gene works a little bit. And the enzyme activity can help me determine it, but the reality is, what's the difference between Hurler-Shea and Shea? Well, one of the big things is the brain is actually able to myelinate. So they don't have as much cognitive issues once the brain is myelinated, whereas in Hurler's, it happens so early and it starts accumulating so early that it results in very severe cognitive deficits. Enzyme replacement, Aldurazyme, has been approved for clinical use, and it's so if you can't make the enzyme, give it through an IV. Early studies have shown improvement in organomegaly and skeletal features. The problem is it doesn't cross the blood-brain barrier. So in Shea and Hurler-Shea, the enzyme activity, there was a little bit of enzyme activity and there was not accumulation, and the brain was able to myelinate, and they still have that continued little bit of enzymes. So giving the enzyme is actually a treatment for patients with Shea and Hurler-Shea. The earlier we start, the better off we are. We do give it to patients with Hurler's, but unfortunately, they can continue to have ongoing cognitive deficits. One of the other things that when we do it as part of newborn screen is a bone marrow transplant. If we do a bone marrow transplant in a young infant, those new bone marrows can then cross the blood-brain barrier and bring the enzyme. And so that's one option. Unfortunately, there's morbidity and mortality involved in that, but and hopefully I'll have to probably retape this next year if there's gene therapy. Anyway, a study which can be used to determine if an individual has a mucopolysaccharide disorder is serum amino acids, urine organic acid, serum from glycosaminic glycans, lactic acid, or serum carnitine, and the correct answer is urine for glycosaminic glycans. You're looking for those unmetabolized sugars in the urine. Hunter syndrome is MPS 2, so mucopolysaccharide disorder 2. It's X-linked recessive. It looks very similar to Hurler's. Presents a little bit later, between 2 and 4, and the disease is only seen in males. Female carriers, so if they have 2 X chromosomes, just one working, even with X inactivation, results in no symptoms. So clinical features include progressive developmental delay, hearing impairment, progressive thickening of the heart wall, again, very similar to Hurler's, growth deficiency, but they can have a little bit of aggressive behavior. But unlike Hurler's, and this is a big differentiation on exam questions, is no corneal clouding. They may have progressive visual loss due to pressure on the optic nerve, but they don't have corneal clouding with that, ground glass appearance, and they can also have this nodular skin lesion. So one of the mnemonics for Hunter syndrome is the hunter with the crossbow, which is an X that can hit his target, because you can see. Diagnosis, elevation of dermatan sulfate and heparin sulfate, same as Hurler syndrome. Enzyme deficiency, iduronate synthetase. Mutation of the IDS gene is identified in most patients, and enzyme therapy is also available. So here was the problem in Hurler syndrome. Here, this first step is the issue with Hunter syndrome. I'm going to move on to Sanfilippo. Technically, they say Sanfilippo is the most common, except for really they call it Sanfilippo, but there's 4 different types. So, whatever. They're all caused by different enzyme deficiencies, and they're all autosomal recessive, and enzyme therapy is currently being studied, but it's not clinically available. Here are the all the different genes. You do not need to memorize these genes. I will not ask you. I'm just showing this as an example. They're all recessive, and they're all due to different enzyme deficiencies. Okay, so Sanfilippo, A, B, C, and D are different disorders, but let's just look at why they were called Sanfilippo. I always think about Hurler syndrome kind of affects everything. It affects hepatosplenomegaly, cognitive, eyes, joints. Sanfilippo has far more severe hepatosplenomegaly, progressive coarse facial features, progressive cognitive delays, progressive athetoic movements, but normal skeletal features. There's no joint involvement, so they don't have joint involvement like Hurler's. Urine glycosaminoglycans only shows elevation of heparin sulfate, and there's no treatment currently available for this disorder. So, unfortunately, because of how they do it, there's really no treatment, although if this was diagnosed early, a bone marrow transplant would be a possibility. This is, I know I've shown you this before last year. This is actually a really good one of the pathways. So we're going to get from the MPS to some other lysosomal storage diseases, and you can see this pathway. They all kind of merge into ceramide. And the next thing we're going to talk about is Gaucher disease, which is glucocerebroside to ceramide. So Gaucher disease is autosomal recessive. It's caused by a mutation of the GBA gene, and the enzyme is glucocerebrosidase, the most common of the lysosomal storage diseases. And it occurs in about 1 in 500 in the Ashkenazi Jewish population. It's about 1 in 50,000 in the general population. So the problem is ceramide, glucoceramide is ceramide attached to glucose, and this enzyme separates them, so you get to ceramide and you release the glucose. Features include fatigue, thrombocytopenia, hepatomegaly, growth retardation, pathologic bone pain, neurologic issues. There can be progressive cognitive deficits, anemia, splenomegaly, avascular necrosis, osteopenia. So here we have, this is like one of the path things. Here's an inclusion body, and here we have Kupffer cells, and it's almost like a newspaper, like a wrinkled up newspaper. So those were historically signs. And so the problem is the macrophages, because of this accumulation, cause issues, cause avascular necrosis. The hepatocytes are spared, but we have Kupffer cells resulting in liver issues, osteoclasts, pulmonary issues because of alveolar macrophages, and causes problems in the macrophages of the spleen, resulting in inflammation and enlargement. So common features include hepatosplenomegaly, bone disease, thrombocytopenia, anemia, growth retardation, bruising, bleeding, fatigue, bone pain, and if your belly was that big, it would probably hurt. Treatment, hematologic. This is historical treatment. If you're anemic, give iron and vitamins. If you're really anemic, give a blood transfusion. If your spleen gets way too big, take it out. Skeletal, a lot of pain management, joint prosthesis when we have avascular necrosis, fracture management, calcium supplementation, cord decompression. Synthetic enzyme replacement has been available for Gaucher for about 30 years, so we have some long-term data on it. It's administered IV every 2 weeks, and there are also oral medications. Patients on these therapies show improvement in the first few months. And so this is the earlier studies when they started taking patients that had Gaucher disease and put them on enzyme therapy replacement. Their hemoglobin increased by 2.5 grams per deciliter in 9 months, and a 50% increase in platelets, so we didn't have to take out their spleen. Hepatosplenomegaly, 20% decreased size of the liver, and 45% decreased size of the spleen. Now, we actually, the only people I actually have enzyme therapy now are kids, because substrate reducer has not been approved for children, and yet it's the standard of care for adults. So a substrate reducer inhibits the synthesis of the product glucocerebrosidase. So if you can't break down as much, don't make as much. So it's actually, it decreases the amount of this thing that we can't get rid of. And hopefully the residual enzyme is sufficient to prevent progressive accumulation. These are oral medications, and there are actually 2 medications in clinical use. One of the things we do is pharmacogenetic testing to see everybody metabolizes medications at different rates. So these particular medications, we have to make sure that they're not what's called an ultra-rapid metabolizer. That way they break down the medication before it would be of clinical use. And it's now the first-line therapy in adults. So I don't even have any adults on enzyme therapy. The only people I have on enzyme therapy are kids, and I usually move them over to the oral medication around 16. I like to get them over to that before they go to college so that, they don't miss other stuff. Results, as far as long-term results, are very similar to the IV for decreased hepatosplenomegaly and bone disease. Carriers of one mutation of the GBA gene has recently been noted to increase the risk of developing tremors, which looks a lot like Parkinson's disease and can be clinically diagnosed as Parkinson's disease. So, for instance, if you saw a family history of somebody with tremors, maybe they actually, and there's a family history of Gaucher and they have tremors, maybe they're a carrier. So, a 48-year-old Caucasian male of Ashkenazi Jewish descent, as I said, it's very high in the Ashkenazi carrier, having Gaucher is actually very common in the Ashkenazi Jewish population, has thrombocytopenia. The most likely diagnosis is familial idiopathic thrombocytopenia. Again, the word idiopathic means I'm an idiot because I don't know what causes it. So try never to pick anything that says idiopathic. Fabry disease, Gaucher disease, hemochromatosis, or Niemann-Pick type C. And so he's Jewish. He's got hepatosplenomegaly, thrombocytopenia. So this would best fit with Gaucher disease. The next disorder I want to talk about is Pompe disease, or glycogen storage type 2. And this is like a lysosomal and a glycogen storage disease. I want to first talk about the infantile form, and this is really no enzyme. Progressive muscle weakness characterized by a low muscle tone or hypotonia, head lag, delayed milestones. Respiratory complications, including frequent infections and sleep apnea. Significant cardiomyopathy resulting in early death. Cardiac complications, here's the heart. It pretty much takes over this entire x-ray here, and usually seen by 4 months of age. Short and PR intervals, tall QRS, Wolff, Parkinson, White. Basically, the heart's not functioning, it's too big, and the electrical system is being affected. So, failure to thrive postnatally, and part of the failure to thrive is their muscle tone is too low. They can't coordinate suck and swallow, so they start losing weight. They also have a big liver and macroglossia. Macroglossia and low muscle tone is really not a great combination. Cardiomegaly and hepatomegaly and cardiomegaly are probably increasing your metabolic needs. Therefore, not being able to eat enough makes it even worse. And marked elevation of plasma creatine kinase, or CPK. I said it before when we were talking about Duchenne, CK is a sign of muscle damage. And so these muscles are having issues and the CK is elevated. We also see elevation of liver enzymes, AST and ALT. Confirming the diagnosis, enzyme analysis for acid alpha glucosidase. This enzyme can be done on a dried blood spot, and we now in Illinois actually test for all the lysosomal storage diseases, but I will never ask you, nor will the boards, about what's on a newborn screen because every state tests for different things. But one of the major problems in the heart is healthy myofibrils are replaced with glycogen. And so you can see this glycogen kind of in between the myofibrils, and this results in the low muscle tone and probably also results in the abnormality in the electrical system of the heart. Now, they actually did a movie with Harrison Ford on the management of Pompe disease. So symptomatic treatment, imagine you give pressors, do physical therapy, you're going uphill against, tidal wave. Lumazyme is an enzyme replacement currently available. It received FDA approval faster than any medication previously. Bone marrow transplant, a few have been performed. The outcomes are not encouraging, and the reason is by the time we diagnose this baby, they have low muscle tone, they have a big tongue, they're not able to eat, they're at risk of infections, and most of them succumb to the disease. And here is, unfortunately, the survival curve of infantile Pompe, and basically they're mostly deceased by about 10 months of age. And this is a group of patients for giving Lumazyme, and you can see here we are at around 9 months, and they're all surviving, and even out to 20 months, we've lost a couple, but the vast majority are surviving. So when this data was given to the FDA, they're just like, okay, usually when you look at a curve, it's like this versus this, not like such a dramatic change. And so this was actually given FDA approval. Having said all that, that is not as common, the infantile form, as the adult onset. So infantile Pompe, no enzyme. The adult form is also caused by mutations in the GAA gene and is far more common than infantile form. Again, deficiency or acid alpha glucosidase enzyme, and characteristics include progressive muscle weakness, especially proximal, elevation of CK, cardiomyopathy, and restrictive pulmonary disease. But the cardiomyopathy is not as pronounced as the infantile form, but it can look a lot like limb-girdle muscular dystrophy. Hard time going upstairs. It just seems like it's getting worse. The great thing about this, though, is this is one of the few that we can actually do something about. So enzyme therapy that we made for the kids and got approved by the FDA can be used. We actually just last week approved a new medication with a different name that you do not need to know, that gets into the cells better. So I'm hoping, my problem with a lot of these adults is I have about 5 that I'm infusing right now, and they just seem to get a little bit worse over time. Okay, remember we talked about the mucopolysaccharides. Some affect everything like hurlers, some don't affect the joints like Sanfilippo. While Tay-Sachs, what sucks about Tay-Sachs is it's a mutation of the hexosaminidase A gene, and it results in lipid accumulation in neurons, so it only affects the brain. The baby doesn't look coarse, doesn't have a big liver or spleen, it only results in accumulation in the brain. And here's this cherry red spot. No contractures, no hepatosplenomegaly, it's autosomal recessive, and individuals of Ashkenazi Jewish descent, 1 in 30 are a carrier for this gene. The general population is 1 in 300. Having said that, for the past 3 generations, most individuals of Ashkenazi Jewish descent have had carrier screening for this. So the vast majority of babies born in the United States with Tay-Sachs are not Jewish, because there is a carrier frequency of this. It's 1 in 300. So like I said, even though it's thought of as a Jewish genetic disease, because most individuals of Ashkenazi Jewish descent have had Tay-Sachs carrier screening for literally since the 70s. It's usually when we actually see a baby born, unfortunately, it's usually not in that population. Niemann-Pick. There are 3 types, A, B, and C. They're all recessive. They're all different enzymes. And they're all caused by inability to break down lipids. So it's a deficiency of the enzyme sphingomyelinase. Type A, more severe, Ashkenazi Jewish population, carrier frequency 1 in 90. Type B, no neurologic symptoms. Type 3, unable to metabolize cholesterol and lipids, resulting in the accumulation of lipids in the spleen, progressive ataxia, and cognitive delay. Can present in infancy or early childhood. Gene testing for MPC1 is available, and mutations are found in about 90% of patients. And there is a treatment in clinical trials that helps clear the cholesterol and lipids from the cell. So, a 6-month-old male has lost developmental milestones, including smiling. He has staring spells, and the family history indicates his parents are both of Ashkenazi Jewish descent. Consanguinity is denied. There's concern he may have Tay-Sachs, which I spelled wrong. Which enzyme analysis is recommended? Iduronate sulfatase, hexosaminase A, alpha glucosidase, hexosaminase A, or alpha glucosidase, and the correct answer is D. So, you give a scenario, and then they tell you what they think it is, which, makes you crazy. Because it's like, okay, I think this is Tay-Sachs, and then they're like, what enzyme is it? So, those are the different level test questions. So, in conclusion, enzyme therapy cannot cross the blood-brain barrier. Therefore, neurologic symptoms cannot be reversed once they've occurred. Early diagnosis can result in a better prognosis or outcome for LSD where enzyme therapy is available. As new treatments become available, the early diagnosis is critical to improve prognosis. And as I said, Illinois is actually one of the first states to offer lysosomal storage as part of our newborn screen for pretty much all the lysosomal storage diseases that I have discussed today. And it allows for early diagnosis as well as long-term treatment. And correct diagnosis also allows for genetic counseling for the family. So here's a couple USMLE-like questions that I took out of some of these books. A 50-year-old female has recently diagnosed with a movement disorder, Parkinson's disease. The family history is positive for her father, who was diagnosed with Parkinson's at 60. She has a 55-year-old brother with Gaucher disease. He has no symptoms of a movement disorder. What gene is likely related to her symptoms of Parkinson's disease? And the answer is the gene. So the first one causes Fabry, Gaucher, MPS1, and hexosaminidase A for Tay-Sachs. So, and again, I didn't write this question. I took it out of a book. A 2-year-old boy is diagnosed with a biochemical defect involving hexosaminidase A. The patient's condition would be most appropriately categorized as to which of the following general classes: amino acidopathy, gangliosidosis, carbohydrate metabolism, mucopolysaccharides, or porphyria. So this is Tay-Sachs because it's hexosaminidase A, and that affects the gangliosides. So that concludes this presentation. Thanks.